Perfect. So it's done? Fine? Okay, thank you so much. Sorry for keeping you waiting. My name is Bilal Koleilat, and I come from Lebanon. For the translation, if you feel that I'm speaking a little bit fast, just wave your hand, okay? And so let's get the show on the road. So I'm going to talk about three things today. First, I'm going to remind you about the things that we know, just a simple reminder. Second, I'm going to talk about the things that we really need in the orthodontic profession. Once we know those two things, then we are well informed. And if you are well informed, you can be transformed. So, ladies and gentlemen, I come from Lebanon. My name is Bilal Koleilat. I work in Beirut, and I work also in Dubai. I did my master's degrees in Finland long time ago. So the title of my presentation is One for All and All for One, and I want you really to think, why did I choose this title? Because there's a gift for somebody, one of you, to win at the end of this lecture. So what do we actually know? And if you want the truth, you need to go to the numbers. And I did a small survey, and I came up with those four titles. And I want you just to help me find the numbers, right? So what do you think in the United States, UK, and France is the most used size of slot? Is it 18 or 22? Yes, it's 22 in the US, in the UK, and in France. Second question, what do you think is the most used system, like, let's say, Damon, self-ligation, MBT, Roth? Let's say in USA, what do you think is the main system used? Okay, anybody says anything else? Okay, so 41% of the orthodontists in the United States use the MBT. In the UK, it's almost 82%, even though Bennett is from the UK, but McLaughlin is from USA. But it seems then the MBT has more influence in the UK. In France, the number one used system is Roth, and I was a little bit surprised. The second most used in the USA is standard edgewise, so it seems a lot of orthodontists still like to bend wires, put torque, which is something that I really respect. The second most used system in the UK is Roth. The second most used system in France is MBT. The third one in the US is Roth. Type of self-ligation, only 15% of the 22% in the United States use Damon. And, you know, looking at the social media and all the conferences and the money spent, you are really surprised that only 22% of the orthodontists use self-ligation, and out of those, only 15% use Damon. And I guess in the United States now, the rising star, it's the PIT system. Less than 10% in the UK use self-ligation, so it's barely non-existent. And in France, I was also a little bit surprised about the numbers. More orthodontists use active self-ligation than passive, and only 15% use Damon. And if you ask the reason, according to the survey that I went through, in the United States, they use self-ligation because either they have big practice, and you know the system in the United States, they have dental assistants using the system, so it's user-friendly. In the UK, they say we use the MBT because this is how we are taught. So they're really trained to do what they're taught in their clinics, the things that they do in the university. And there was no reason for the use of Roth or MBT in France, so the orthodontist didn't give any specific reason. So what do we actually really know also? This is a very famous article by Melson and Dalstra, is that people don't use self-ligation, and she says that orthodontists prefer to use conventional because we have torque issues when we use self-ligation. Now, if you ask orthodontists who are using Roth and MBT, especially in the UK, can you find a difference in the final torque between cases treated with MBT or Roth? They can't find any difference. And do you know why? Because If you use Roth, which has 12 degrees of torque on the upper central incisor, and you use MBT, which has 17, and your final wire is 1925, you get only half degree of torque expression with the Roth, 6.5 degrees of expression with the MBT. So that's why there's no difference. So basically, I don't understand why orthodontists around the world, they use MBT or Roth, they have a preference for this system or the other system, if at the end, you don't get the torque that you want. And if you look at the case, you don't know if it's been treated by Roth or MBT out of the final position of the upper incisors. So it doesn't make any sense to me. To add to the problem, this is a very shocking study. If you take a bracket set from any brand in the market, you're supposed to have identical brackets on the upper left central, upper right central, but you don't. Even on the premolars, on the laterals, there's a big chance that 20% difference in the slot and in the fabrication of those brackets in the same set. I used to think, okay, well, if I buy brackets in 2020 and in 2022, there's a difference in the manufacturing because it's been 2 years difference. But the problem is not that. The problem is in the same set. So what's the solution in the literature? Clinicians may consider improving torque problems by using high torque prescription. Low, average, does it ring any bell to you? Does it give you any memories? Who's using low, average, standard? Or add torque to the arch wire. And this is why 32% of the orthodontists in the United States still use standard edgewise. Because they're not happy with the self-ligation system that they have between their hands. That's the only thing. So what do we actually need? We need the transformation. And I'm going to show you a 1-minute video. I hope the sound works well. About a transformation. Can we dim the lights a little bit? Can we dim the lights a little bit? It's a transformation that every orthodontist needs to go through to be able to have a happy practice after a certain amount of years.
The story of the eagle's reverse.
The eagle has a 70-year lifespan. In its 40s, its talons can no longer grab prey. Its beak becomes too curved, its feathers too weak. The eagle is left with the choice to die or to go through a long and painful transformation. Transformation requires the eagle to fly up high on a mountaintop. The eagle breaks off its beak by plucking it against a rock. The eagle plucks out its talons and feathers, then waits for everything to grow back. After 5 long months of suffering, the eagle takes its famous flight of rebirth. As the eagle must change in order to survive life, so must the golfer change in order to survive the game of golf. Golfers must get rid of bad habits. The golfers must have the best tools. Like the eagle, the golfer must evolve.
So like the eagle, a golfer must change. And I think if the orthodontic profession can be compared to a sport, it should be compared to golf. Because there's so many things in common between golfers and dentists. Among other things is lower back pain. But if you want to change, if you want to have a different orthodontic profession, we need to change. And in order to do that, you need to have a very difficult transformation. So while I want to become that eagle and stay, flying high, and I'm sure that all of you want to stay as eagles, the problem is that when we use certain appliances that we have on the market and certain systems, they're so confusing that I'm not an eagle, I become a chicken. Because it's so confusing. I don't know how to use those systems. I want to fly high. Using those systems, I get grounded on the floor and become a chicken. So I'm going to show you through 4 cases today how am I able to use the Genius system to really fly high, and I hope that you take that trip with me. So what I'm going to show you today, what a precise bracket manufacturing can do, a controlled torque through a reduced slot, biocompatible low-force initial wires and their capability of expanding the arches, simple and reproducible mechanics through the system that we all know, which is the Genius system. So the first case is a very dear case to me, because when this young girl, who's 15 years old, came to the clinic with her father, I've never seen her mom actually. She came with her father, and she said, look, when you want to take the pictures, can I not smile? Because I can't smile. I don't want to smile. I've been bullied at school, okay? And she always looks, look at her eyes. Look at the dark area around her eyes. She always seems very unhappy, this girl. And when I take a close-up look, there's something wrong with those two central incisors. It's like one of them is trying to hit me in the face, and the other one she's probably trying to swallow. And the other thing also is that she's showing the canines. And I take those intraoral photographs, and I say, oh my God, how am I supposed to treat this case? She doesn't have lateral incisors. She has a huge torque difference between the 11 and the 21. Look at the long crown on the lower right central incisors, and a complete blocked-in canine on the lower right side. And I'm very, very rarely faced with a case where I don't know what to do. I really don't know what to do. And when I get in these kind of situations, I always go back to the profile. Because I like my treatment plans to be dictated by aesthetics and not by teeth. Okay? Because what we try to do in orthodontics is to change the smile, which is going to change the life. Okay? I'm not going to treat her according to cephalometric analysis, because if I'm not happy with the aesthetics at the end, I'm not going to give her a copy of the cephalometric values to keep in her pocket. Whenever she's not happy with the way she looks, she can read the values and say, no, but the values are good, I don't care. So if I'm always faced with this kind of problem, I look at the face. And the face tells me, Bilal, you need to preserve those lips as much as you can. So this is the ceph. And take a look at this central incisors, which is the 21. It's completely vertical, and it completely has no bone on the buccal side. So why did I show you the problem with the torque in the beginning of this lecture? It's because the most difficult thing to get for an orthodontist is a good torque on the upper two central incisors. And look at this case. So we started with the Genius, and you know the sequence of wires. I'm not going to go through that. We start most of the time with the 14 thermal ultra, and then the 18, 1425, 1825, and then I try as fast as possible to go to the steel so that I can express the torque that I want. And opening space with a light coil and waiting. The most important thing in orthodontics, if you want to use the thermal ultra wires, is to wait, is to give time for those wires to work. We orthodontists, especially sometimes me, we are in a hurry to change those wires because we think that, by changing the wires, we get the teeth moving fast. On the opposite, if you change the wires too fast, you get the teeth not to move too fast. So just let those wires cook. And I let those in there for almost 5 months. I left the 14 thermal ultra for 5 months. Okay? Just measuring the coil, opening the space, and then I went to opening all the space, and you can have a look also at the position of the lower incisors that has not changed from the beginning till the maybe 3-4 months into the treatment. And once I got enough space for the lower right, for the 43, I bonded an eyelet, threaded through a 14 thermal ultra, biturbos on the 2 upper central incisors, and look at the position of the 2 central incisors just by giving time for every wire to express its full potential. And then I used a 1925 TMA just to detail a little bit the two central incisors. No torque added on any part of the wire. And actually, this really surprised me that I didn't have to add any kind of torque to get those two central incisors where they are at this position. And this is in June 2022, just finishing. This is a composite picture of how we were and how we are now, the before and after. And this is the debonding. I did a little bit of gingivoplasty, and we built up the two canines to look like lateral incisors. We added a little bit composite on the premolars to make them look like canines. And look at the occlusion. I never thought I can finish this case so well, but you know, I have the Genius system. I should not worry, because it's so precise, it's so well manufactured, that if we tell you that we're going to give you the torque, we're going to deliver. It's a system that we can trust. And look at the before and after. I think I was not only able to change the smile, I was able to change a lot of things in this girl's life. Look at the position of the upper central incisors and the lower, and look at the beginning, the level of the gums, and here. Nothing much has changed. So this idea of expanding the arches, you know, proclining the lower incisors, thinning the bone, if you do it properly, if you do it slowly, with the proper wires, you don't have to fear that. This is the before, position of the central, and take a look at her now, how she's smiling. And now she wants to smile. She wants to have friends. She wants to go to parties. 2 years of treatment changed the life of this girl for a lifetime. Second case. Again, I'm only showing you difficult cases, okay? So, 14-year-old girl, she's very funny, very cute. She comes to the clinic with her mom. Again, look at the profile, very thin. I like those lips. I'd like to keep the eversion of the upper lip. She has a small nose, constricted upper jaw, and she has also a missing 12 with severe crowding on the lower. Very thin biotype. Well, if somebody wants to tell me that I'm going to do this as an extraction case, okay, it's fine. So what are you going to do? Basically, the protocol in these kind of cases is to extract this upper lateral, because we in orthodontics like harmony and balance more than anything else. Because you have one missing lateral, you extract the contralateral, and you extract two premolars in the lower, and then you end up, you know, bringing all the teeth inside, dishing in the face. It wouldn't be a problem after 2 years of treatment, but if you're going to see your patient after 10 years, definitely you're going to be shocked. Look at the position of the lower incisors, very upright, and the upper incisors also upright. So again, the use of the Genius system, of the low force that the wires can give me to enlarge and expand in a biocompatible way, okay, with early elastics. And I leave the 18 Thermal Ultra for 10 weeks. This is something that I had to get used to, because, you know, during my profession, I started with the Vic Alexander technique and then went to Roth, from Roth to MBT, from MBT to Burstone, from Burstone to the bidimensional Rocky Mountain Synergy brackets. So I basically used everything. And I'm not used to keep the wires in for a long time. But now I'm forcing myself to keep those wires, and look what happens. The only way you can enlarge upper and lower arches with low forces is when you use round wires. It's been 4 years I'm using the Genius now. The things I don't buy anymore in my clinic are extraoral headgear. I gave them to my colleagues. Bands. I don't use bands anymore. I don't use lingual arches. I don't use TPA. I don't use transpalatal bars. I don't use those anymore. I try to make my mechanics as simple as possible, as predictable as possible. So leave your wires, the 14, the 18, leave them. 4 weeks, 5 weeks, 10 weeks, until the wire is completely dead. Then you can remove it, put another one, and then again, let those wires work. 18, and then we switch to, I'm jumping a little bit. You go to 1825 on the upper and the lower, and I always reposition brackets. When I was in Finland in training, I used to be taught that you need to position the brackets at a certain level, don't touch them anymore. But why? It's not sacred, okay? If I see, I always take pictures every month of the smile of the patient. I like the smile arc. It's sacred for me to have the upper 6 front teeth following the shape of the lower lip. If they don't follow the shape of the lower lip, I feel that my case is completely messed up. If I need to remove the brackets, put them back again, upper, lower, depending on the smile of the patient. So I reposition some of the brackets, and I go to 1625 stainless steel, and I feel in a lot of cases that's a magic wire because it's stiff enough to hold the shape, okay? But it's not too stiff to give me all the torque that I need because I need to keep my upper incisors upright. Now, one thing that I learned, the more you upright your upper incisors, the more when the patient takes a picture of himself or herself, all the upper incisors show. It's all, the flash hits the upper incisors, it looks more white and it shows more. We orthodontists have a tendency to incline a little bit the upper incisors. The more you incline the upper incisors, the less they show. The less they show, the more you show lower incisors. The more you show lower incisors, the older your patient looks. If your patients are below 20, try as much as possible to reduce the show of the lower incisors. Let them show upper incisors full. A couple of millimeters of the gum is fine because we know with age the upper lip is going to drop a little bit and it's going to harmonize with age. So I'd like to keep my upper incisors really upright. Prior to debonding, always taking picture of the smile just prior to removing the braces, before and after, and take a look at this occlusion. No extraction of any tooth whatsoever. Now, this is not enough. She goes to vacation. She leaves for 2 months. She comes back. This is the before and after. And 2 months after the debonding, we build up the 14 and the 23. And if you look at this picture, I bet any one of you can tell me if there's anything wrong or missing or build up. Now, this is what I call smile aesthetics. She's a beautiful girl. Third case. This is a case that I've done in Dubai, and they required me to hide the eyes. She's a 22-year-old female, and she comes, she says, look, Dr. Koleilat, I need to get married after 2 years. And I told her, it's not my problem. You need to go find your own man. She said, no, I need to fix my teeth in under 2 years. We're going to say, okay, no problem. So that's the most important picture during any treatment that I do. I tell them to smile. If they show the whole upper incisor, I want to keep that. I try my best with my mechanics to keep that. The extreme deep bite, full class 2, constricted upper and lower arch. Again, when you're faced with a problem, should I extract or not? Go back to the profile. Would you like to extract on these kind of profiles for a 22-year-old? Yes, you can, of course. It's not the problem of extracting or not extracting. It's how are you going to end up with the profile. Orthodontists, we have a tendency that if we want to find space, we always procline. We never think about the posterior space. Upper incisors and lower incisors need a lot of work. So again, genius at the rescue. And I like to use, in class 2 cases, I like to use class 3 elastics. Does it make any sense? It doesn't make any sense. In class 2, I use class 3. And in class 3 cases, I like to start with class 2 elastics. So let me just explain that. so that doesn't become really confusing and we become all chickens. So in class 2 cases, if you use class 2 elastics, you're going to have problem proclining the lower incisors. So while you try to align and level the lower arch, try to use class 3 elastics to keep your lower incisors where they are and to level your curve of Spee by pushing and extruding premolars and molars backward. So this is what we call en bloc movement of the posterior teeth. So this is what I've done, coil spring, open space. And I felt that I need something else to help me. So I use a lot of micro implants. I went for 2 IZC, infrazygomatic crest, at the level of the 7, 2 millimeters diameter, 12 millimeter long, and I'm using them to distalize the whole upper arch because we ask the patient to extract third molars on the upper and the lower arch. And not only that, I'm also asking the patient during the night to use class 3 elastics from the micro implant to the lower arch because I want to flip the whole lower occlusal plane backward. I want to level the occlusal plane by moving the whole teeth backward. And I use a lot those sling chain to keep detorquing my lower incisors. And after 2 years of treatment, this is the day we debonded the case. And look at that smile. She can't believe that she has that smile. I can't believe that we got her to this point. And not only that, Ashley yesterday asked something very important. Who among you does bleaching? Well, a couple of us raised our hands. I did not believe in the power of white. Take a look at that. She did whitening. She got married. She came back. So I can take those pictures. It's a big difference between this and this. And if you only want to take one message out of my lecture today is that please offer whitening to your patients. Your pictures would look much, much better in any album or any workbook. And that's the final result after the bleaching. I think she is in love now after getting married. Fourth case, and this is my final case. I showed this last year in Como, but I think it's a case that I want to show again because it really shows the power of the Genius system. And if really used to the maximum, you can get beautiful results in very short time. So this is a 17-year-old man. He came to me because he said, I have a twisted smile. There's something wrong with my face or my teeth. And I told him, well, you have a twisted smile, you have a cant. We try to explain. And now I'm going to go on Monday, try to explain less technical. And he has a cant of the occlusal plane, edge to edge, open bite, tendency to class 3. So all the problems in the world when it comes to orthodontic profession is in this guy's mouth. So I'd like to start everything together. I call it the orthodontic salad. What does it mean? I'd like to address sagittal, vertical, and anteroposterior problems and transverse problems. I'd like to do everything at the same time. Why? Because the patient, for the first 8 months of the treatment, they're very motivated. If you give them elastics, if you give them headgear, if you give them whatever you give them, they really are motivated and they are cooperative. So I'd like to use class 3 elastics, open bite elastics, expansion. I use Kaplan hooks for crisscross elastics so I can expand the upper arch. So everything goes in together. And after the 5th month, look what I got. You know, sometimes I don't know if I'm good or I'm lucky. Most of the time I'm lucky. So after the 5th month, and the patient said, can we take the braces off? And I said, no, you know, I told you need 2 years. But we always say 2 years because we never know how long the treatment's gonna go. So, and what am I going to do for the next 7 or 9 months? I'm going to detail the occlusion. I'm gonna have fun. I'm gonna love the case. I'm gonna try to put every tooth in its ideal position. Why? Because I have time. The system helped me resolve the problems very quickly. I'm gonna have time finishing and detailing the case. And this is what I lacked. This is what was missing in my practice in previous system. Because I had problems with the torque, problems with the elastics. We only use elastic. We were taught, and this is still practiced now, we are only taught that you can use elastics after you go with the heavy stainless steel arch wires. So after 1 year of treatment, you go on 1925 stainless steel on the upper, 1725 steel on the lower, and you give your patient 6.5 ounce of elastics. And I think you're going to be very lucky if the patient is going to wear them for 2 months. And after 1 year of treatment, he's going to start nagging, complaining, when am I going to finish? That's why I like to do things very early. Let him use very light elastics, 2 ounce from day one. So the rest of the time, I'm going to detail the occlusion, and we're going to end up with this kind of result after just 11 months and only 10 appointments. Is this amazing or not? So we went from open bite to complete closure, class 1, correction of the cant in only 11 months and 10 appointments. So I have a small surprise for you. It's finally out. I've written a workbook. It has 5 cases in it. And the first guy who's going to get a copy, of course, is Charlie. So this is something that you can display, and this is for you. And why did I do that? Because I want to take you back to the first slide. Why do people use MBT? Because it's a super system? It could be. I'm not the one to judge. Because there's a guideline for it. We like it because there's a guideline. If you do this, if you have this, you do that. If you have this, you do that. And I've also, when I was writing this workbook, I also was thinking about the salesman and the dealers. Because I know how hard it is when a salesman go to an orthodontist. He knows he's using, let's say, a rubbish system, but he doesn't know how to convince him because he doesn't have cases to show. He doesn't have scientific evidence in his hand to tell him, look, please try the system that we have. Okay? So when I was writing this, I was thinking about the orthodontist, the dealers, the salesman. So So the question is, do you have any idea why I called my lecture One for All and All for One? And those who know what the answer is going to get the second guidebook as a gift. So does it ring any bell, this phrase? Les mousquetaires. Très bien. So we are all a team. We are MEM, Ortho Partner. We have the Genius Master Program. We have the Genius Summit. We have the workbook. And I've created also a couple of years ago a Facebook page where we Genius users share a lot of cases and tips. What does this has any benefit? You know, because the problem with the orthodontist is that when they use a system, they buy, they pay money, and then the company or the dealer, they just leave them and they go. I'm trying to tell you that if you want to start using the system, you're not alone. We got your back. We are here for you. If you want to learn, we can teach you, we can have fun, and when you learn, you will become part of our summit, part of our team. We have a book for you to follow, and Musketeers, so you won the book. And I'd like also to quote Vin Diesel in his movie, the most important thing in life will be a family. So we're not only orthodontic colleagues, we are all here, the genius people, we are all here as a family. And I'm gonna leave you with this beautiful song at the end. Thank you so much.
It's been a long day without you, my friend, and I'll tell you all about it when I see you again. We've come a long way from where we began. Oh, I'll tell you all about it when I see you again. When I see you again.
Damn, who knew? All the planes we flew, good things we've been through. That I'll be standing right here talking to you about another path. I know we love to hit the road and laugh, but something told me that it wouldn't last. Had to switch up, look at things different, see the bigger picture. Those were the days, hard work forever pays. Now I see you in a better place. How can we not talk about family when family's all that we got? Everything I would do, you were standing there by my side. And now you gon' be with me for the last ride.
It's been a long day without you, my friend. And I'll tell you all about it when I see you again. We've come a long way, from where we began.
You know we started.
Oh, I'll tell you all about it when I see you again.
Let me tell you.
When I see